Hi everyone, I'm Manas and I'll be talking about ConverSense, a way to assess patient-provider interactions using social signals. This work was only possible due to a close collaboration between UC San Diego and the University of Washington. Patient-provider communication is very important towards the patient's health experience. A good patient-provider interaction leads to better diagnosis, better adherence, and in turn, a better emotional and functional well-being. While improved communication can drastically alter the visit experience, present day communication feedback practices are largely based on, say, self reflection, where providers would just go home, think back on the visits in the day, or figure out if they said something wrong. Or patient rating, where sometimes clinics give them anonymized feedback reports of all the patients that they saw in a month, but it's so hard to trace which conversation it specifically was. And finally, sometimes there's also an external observer who sits through the visit and gives feedback to the providers later on. All of these methods are largely manual and hence not scalable. Therefore, there is no clear way to seek reliable feedback for every visit. Hence, we explore if automated sensing and visualization of these communication patterns in clinics can lead to a more patient centered form of care. In the realm of understanding any communication between two people, it is imperative to understand social behaviors they exhibit. In fact, in the clinic, these behaviors have been found to have implications across many dimensions of patient centered care, ranging from visit experience to even uncovering any biases in the providers. At the core of all of these social behaviors lie gestures or nonverbal cues. In our goal to automatically track social behavior, we focus on understanding the relation between these nonverbal cues and the indicators of social behavior, primarily known as social signals. In the context of nonverbal cues or social signals in clinics, there have been three key systems that have motivated our current approach. The Antandra system introduced social signals in the clinics. Through a Wizard of Oz approach, its creators found that social signals are useful descriptors of patient-provider interaction. Further, the EQ clinic system used nonverbal cues based on speech and head movements as feedback for telehealth visits, where the authors found that nonverbal cues were insufficient as a mode of feedback. Finally, the reflective system introduced a real-time feedback of nonverbal cues in telehealth visits. While the users in virtual settings found it to be helpful, authors argued for a more evidence-based norm to predict social behavior. Hence, in our overall goal of building an automated communication feedback system, we summarize a few key considerations here. To start with, we often don't say how we feel, and that's where we explore if nonverbal cues could be picked up. But in studying nonverbal cues, we want to understand what modality to study. We want good content, have an ease of access, and owing to the ubiquity of introducing a microphone in a clinical setting, we focus on vocalic or audio-based cues. In order to map these vocalic cues, we need to understand how we could measure social behavior. And that's where we turn to cognitive science literature to find specific indicators of social behavior. Now, let's say we build a full pipeline to track social behavior. We want users to trust it. Our approach towards this goal lies in using an interpretable and explainable model so that they can be aligned back to clinical findings. And finally, towards exploring the best time to deliver this feedback to the providers, we propose a near real-time approach where the results are available to the providers within minutes of their visit. So let's dive deeper into the specifics of our system, starting with designing the models of social interaction. To formalize the interpretation, we treat social signals as aggregates of behaviors that individual expresses in a social context, and the means for processing these signals is called as social signal processing. More simply, a person could be happy or sad by themselves, but for them to be polite, we also need their social context. And towards this goal, we focus on the Rotor Interaction Analysis System or RIAS, which is the most popular means for scoring patient-provider interactions. It scores different indicators on a scale of 1 through 6, and generally 3 is treated as a neutral behavior. Anything higher implies a stronger presence of that signal, and vice versa. Given their broader use in behavioral sensing, Within the RIAs, we focus our attention on four major social signals, namely dominance, interactivity, engagement, and warmth. To first get a measure of these social signals in the real world, we choose the Establishing Focus study, which is a large corpus of audio recordings of doctor-patient interactions. We randomly sample 10 primary care providers from their corpus and collect all of their interactions, which gives 103 clinical interactions in total. Now, each of these interactions is broken down into slices of 3 minutes, which gives us a total of 531 slices. Each slice is annotated using a manual coding method described in the previous slide on a 1 through 6 Likert scale. And this dataset was annotated by two individual experts so that we could ensure reliability of all the labels. As we coded the data, we realized that the data per each RIAS level was extremely sparse. Then we asked the question, can we still build a system that could give us insights about social signals? And that's where we explore if reducing the number of classes makes a difference. Since the RIAS system largely depends on defining the neutral level of behavior and evaluating deviations with respect to neutral, we cluster these values of all the slices of a score below 3 or above 3. And the table here shows counts of all the slices after this clustering. Despite the clustering, we see that there are barely any samples of low behavior. While this highlights the selection bias in the data, where providers with good communication were the only ones who ended up volunteering to be a part of that study, we propose ignoring the lower labels to build a two-class system that can identify higher presence of any given affect or a social signal. Since patient-centered care largely relies on the idea of letting the patient speak, we model these behaviors through metrics of turn-taking, such as interruptions, pauses, or even talk time. Next, to model descriptors of intonations, we derive various speech-based features. Since individual turn lengths can be very small to capture the full speech feature size, we compile all the utterances by a speaker in a given slice to build the speech feature set. All of these features are finally fed through a machine learning classifier to track the change in the level of each social signal. A deeper dive into our feature set shows how empirical findings are evident in our data. For example, a dominant provider could be one where the patient doesn't get to talk for long, and even after interrupting, the provider could keep talking for a while. Similarly, lower interactivity is apparent when the patient doesn't get to take multiple turns and tends to speak for a lesser time overall. To map our nonverbal cues into social signal levels, we choose a series of globally and locally interpretable models with the goal of validating empirical knowledge or proposing new associations. And to avoid data leakage, we ensured to use a leave one subject out approach to find the best performing models. The table here shows average results of our best performing models. As you can see, all models perform better than chance. While not very high performing, that's the trade-off we choose towards interpretability. Having built social signal processing pipelines, we now discuss how our users, the providers, could interact with them through various levels of visualization. We mark all the neutral scores as 3, while any high score is treated as 5, which is the average of all the high scores 4, 5, and 6. For every visit, the providers can see their overall average affect score as a snapshot of the behavior across the entire visit. They can also break it down based on individual affects in the entire visit. They can further break it down into slice-wise scores over time. Finally, our providers or the users can compare each of these previous metrics between two patients. The goal here is to help them explore if the behavior towards specific patients went higher or lower. Finally, we also design a population view dashboard. Providers here can see if they have varied patterns with users from, say, a specific age across young or old or a different form of race to learn about their inherent biases if they have any. Having designed an AI pipeline and a way for providers to interact with it, we fuse the two together to design the ConverSense system. This section talks about insights on using such a system. We primarily aim to explore two main aspects. First, what part of our tool works or doesn't work, and secondly, what are the implications of using social signals as a mode for communication feedback? To understand this, we invited providers in a mock clinical room setup. They would first answer some basic questions about themselves, then they would see two patients. These patients were actors who were specifically trained on a special script to ensure that their behavior remained constant across all the providers. After the two visits, ConverSense would show them live results for their visits and they could interact with the tool. And finally, they would answer some questions about their experience. Although our sample had a few participants, we ensured a variety of experience to capture a broad range of providers. So here are some of our key learnings on our study across all the 5 providers. First, our pipeline showed the potential to generalize when tested on the new data from visits in our study. Secondly, we learned that providers liked having the ability to access reports right after a visit, but also wanted to have the option of accessing these reports at any time and anywhere. Third, we found from usability studies that while they needed to learn a little to use the tool, the system was easy to learn. And since providers reported a lower cognitive load, we believe that the system could be integrated in the everyday use easily. Finally, one of our users also pointed out that a computational tool will always ensure that the same interpretation and evaluation is carried for everyone, unlike human observers in the clinics who introduce their own biases. Now, on the idea of using social signals as a mechanism for communication feedback, we learned many new things. First, social signals by themselves might not show the complete picture. Everyone's interpretation of being warm could be very different. Further, our study uncovered the need for a more contextualized and actionable feedback. Providers expressed interest in knowing exactly how each behavior could be changed. Third, providers appreciated the idea of comparing with the patient. One participant even said that they often end up reflecting on their poor behavior to figure out if it was triggered by the patient or by them themselves. Finally, when we showed absolute numbers in the tool, providers had trouble interpreting the numbers, even to an extent of suggesting how they could compare to their peers. In summary, we started out with behavioral experts on our team who coded over 100 visits of social behaviors so that we could design an AI system that can track the levels of social signals. We then designed a web-based tool for providers to interact with our AI models through various levels of visualizations. And finally, our lab study uncovered various new insights and described the potentials for using social signals. That brings us to the end of our talk. Thanks a lot for listening in. For more details, please check our paper. This work was a part of a larger project titled Unbiased that aims to infer implicit biases through doctor-patient interactions. This project was only possible due to funding support from the National Institute of Health. We also thank members of the HXI lab at UCSD for their constant support and feedback. Thank you.